Hello everyone, this is Dr. Ankita Singh, Leader, Department of Oral Pathology and Microbiology, Babu Banarsidass College of Dental Sciences. Today's lecture is on developmental disturbances of jaw. Agnathia, it is a rare condition. There is absence of mandible with abnormally positioned ears due to failure in development of jaw. It is an autosomal recessive mode of inheritance. More commonly, small portion of jaw missing. In case of maxilla, maybe one maxillary process or even premaxilla. There is partial absence of mandible, which is more common. The entire mandible may be missing, or condyle, or entire ramus, or bilateral agencies of the condyle and of rami. Micrognathia, as you can see in the picture, there is a small jaw, either maxilla or mandible affected. There is bird face appearance. Micrognathia of maxilla presents deficiency in premaxillary area. Middle third of face appears retracted. There is mouth breathing owing to associated maldevelopment of nasal and nasopharyngeal structures. Severe protrusion of chin, steep mandibular angle, and deficient chin button. True micrognathia could be congenital or acquired. Etiology of congenital unknown, although other congenital abnormalities like Perry-Robin syndrome or congenital heart disease present. Then the acquired type usually result from defect in TMJ such as trauma or infection of mastoid, of middle ear, or of the joint itself. The complications are the tongue falls back and obstructs the airway. There is choking, infections, feeding difficulties, and nasal deformities. Macrognathia, abnormally large jaw or increase of jaw size. This condition could be secondary to other diseases, as in Paget's disease. Prognathic patients tend to have long rami, which form a less steep angle with body of the mandible. The length of the ramus, in turn, may be associated with growth of the condyle. It may be reasoned, therefore, that excessive condylar growth predisposes to mandibular prognathism. Factors which favor mandibular prognathism are increased height of the ramus, increased mandibular body length, increased gonial angle, anterior positioning of glenoid fossa, decreased maxillary length, posterior positioning of maxilla in relation to cranium, prominent chin button, varying soft tissue contours. Then there is facial hemihypertrophy. There is hyperplasia of tissues, enlargement confined to one side of body, unilateral macroglossia, premature development and eruption as well as increased size of dentition. Significant unilateral enlargement of the face is seen, almost equal involvement of right and left side. If we see the classification, it is complex hemihyperplasia, simple hemihyperplasia, and hemifacial hyperplasia. So in the complex one, there is involvement of half of the body, at least one arm and one leg. The affected part may be contralateral or ipsilateral. Simple hemihyperplasia, there is involvement of single limb. Hemifacial hyperplasia, there is involvement of one side of the face. The etiology is unknown, can be vascular or lymphatic abnormalities, CNS disturbances, chromosomal abnormalities. Malformation syndromes are associated with hemihyperplasia and they are Beckwith-Wiedemann syndrome, neurofibromatosis, Albright's syndrome, multiple exostosis syndrome, segmental odontomaxillary dysplasia. The clinical features are females are more affected, unilateral macroglossia with contralateral displacement, roots and crown of teeth often enlarge, may prematurely erupt. The oral manifestation, little information about deciduous teeth, but permanent teeth on affected side often enlarge, more frequently cuspids, premolars, and first molar. The permanent teeth on affected side erupt rapidly. Then tongue, there is enlarged lingual papilla, unilateral enlargement with contralateral displacement. In buccal mucosa, we can see thick velvety folds. may seem to hang in soft pedunculous folds on the affected side. Histopathologic features on tissue examination infrequently reported, generally uninformative. In those cases reported, true muscular hypertrophy was not found. Facial hemiatrophy, which is Perry-Romberg syndrome, progressive hemifacial atrophy, a characteristic loss in soft tissues of essentially half the face. There is slow progressive atrophy of the soft tissues of essentially half the face. Affected side is hyperpigmented. Atrophy is usually confined to one side of face and cranium, may occasionally spread to neck or one side of the body, and it is usually accompanied by contralateral Jacksonian epilepsy, trigeminal neuralgia, nevi, changes in hair, and ocular complications. There is hollowing of cheek and orbit. Jaw bones and roots of teeth on affected side may exhibit delayed development and retarded tooth eruption. Etiology: peripheral nerve dysfunction, local trauma, infection, heredity. Clinical features: it is seen in first and second decade of life. Neurological disorders, ocular findings are 10 to 14%. Maybe pigmentation disorders, vitiligo, pigmented facial nevi, contralateral trigeminal neuralgia. It is seen more in females, more on the left side. Coupe de Sebre, there is painless cleft near midline of face or forehead. This marks the boundary between normal and atrophic tissues. There is bluish hue may appear in the skin overlying atrophic fat. Affected area extends with atrophy of skin, subcutaneous tissue, muscles, bones, cartilage, alveolar bone, and soft palate on that side of the face. Then facial wasting, ipsilateral salivary glands and hemiatrophy of the tongue, unilateral involvement of the ear, esophagus, diaphragm, kidney, and brain scene. Oral manifestation, there is incomplete root formation, delayed eruption, severe facial asymmetry, which results in facial deformation and difficulty with mastication. Then there is hemiatrophy of the lips and tongue, and eruption of the teeth is retarded. So that's all for your lecture. Thank you.